Hi, everyone. Thank you for waiting as we have all of our attendees signing in. I would like to thank you all for joining us today. My name is Chloe Setsos, and I am the project coordinator here at Capital Link, and I'd like to thank you all for joining us. Today's webinar, entitled Cost Allocation Methodology for Value-Based Payment System, is the third in a four-part webinar series offered through the Delta Center for a Thriving Safety Net. The full series, entitled Understanding Your Costs in an Evolving Payment Environment, has been developed by Capital Link with the input for JSI. We'd like to thank JSI, the Wood Johnson Foundation, and the Delta Center for supporting this effort. You can access any recording in PowerPoint from the prior webinars in the series on the website of Capital Link and the Delta Center. Today's webinar will also be recorded and posted on the website as well. If you would like a handout of this specific PowerPoint, you can find that on your GoToWebinar toolbar on the right-hand side. Today's presentation will last about 50 minutes, and we'll leave 10 minutes for questions at the end, but feel free to ask questions throughout the presentation in the chat box located in the GoToWebinar toolbar on the right-hand side of your screen. Today's speakers are Dave Kleiber, who's our project consultant at Capital Link, and Bob Urquhart, consultant and retired FQHC CFO. With that said, I'll turn it over to Bob to get started.
Good afternoon, everyone. Hope you have to bear with me on this. Dave is having some technical difficulties, I think, and he's really kind of the architect of the first part of this, but I'll walk through it best we can, and hopefully Dave will join us soon. Next slide, Chloe. So the first session, we talked a lot about cost allocation, getting the basics right, essentially how to capture and measure costs in the community health center setting. We used a lot of the NAC format in terms of the NAC bulletin on capturing costs. On session 2, we talked about how to prepare internally to gather those costs, what your general ledger would have to look like, what the electronic health record would need to look like, and all of the other supporting systems where you would pull the data to be able to look at your actual costs by a program or by a site or a program or a department. So we spent quite a bit of time on that in session 2. Okay, next slide. So today we're going to talk about some different things. Some of it was a value-based payment system. The definition is going to be different depending upon where you are. Every state has different rules. Every pay has different rules. We're going to talk kind of general what we mean by a value-based payment system. We're going to talk a little bit about how to achieve these outcomes, distinguish between acute care and chronic care, developing what we call clinical pathways, which are essentially treatment plans, and then how do we account for the cost in achieving those outcomes? There are many different ways, time-driven, activity-based costing, estimated costing, but just how would we take those clinical pathways and then develop the cost to go along with those? And next, please. So what is a value-based payment system? It can be many different things, but as the definition of value in healthcare is something that depends on where you are in the chain of service. If you look at the slide, it's defined as the expectation or equation of health outcomes achieved over the entire care delivery value chain. Very fancy words, essentially basically saying, what did we achieve and how much did it cost us to do that? And then how does that compare to as a percentage to the entire delivery value chain? Next, please, Chloe. So what is a value-based payment system? As the slide says, it depends on results, not inputs. So for example, it's not so much worrying about how many things we enter in terms of codes and things like that. It's what are the outcomes? What did we achieve in terms of patient care and patient quality outcomes? Cost is the denominator, refers to total cost, which is everything that's accrued by the FQHC to get the desired outcomes. Next, please. So focus on outcomes. The goal of doing this is basically to look at what's now the quadruple aim of healthcare. We've all heard the triple aim, now it's quadruple aim. Improving patient experience of care, which is very important, and most community health centers really work very hard to do that. improve the health of the populations. So the people that we're serving, what are their conditions, what kind of support they need from us, and how well are we improving their health through their experience with us. Another aim is reducing the per capita cost of healthcare. So how can we provide good care? How can we provide timely care? How can we give the patient everything they need, produce the outcomes that we need, but also do it in a manageable cost, total cost of care. And then the new addition to this is the fourth aim, reducing clinician and staff burnout. This is something that's fairly recent in terms of looking at focus on outcomes, essentially because there are tremendous demands being put on the clinician staff, providers, support staff, looking at providing a wide array of services and care to the patients, and doing it in a pretty much still almost a fee-for-service or 4 patients an hour, 5 patients an hour type of thing. A lot of articles that I've read lately on this topic say that it's a very, very common thing that's happening and growing. I live in the Boston area. A physician from the Boston Medical Center wrote an article basically saying that since the advent of electronic health records and all that's required of a provider to do has created a couple of things. Stress on the provider because they feel as though in the room and talking to the patient, they're not being able to do the things they want to do because they're kind of a slave to the laptop to get the data into the health record. And it also, in his words, it created another condition. We all heard of carpal tunnel syndrome. There's a new syndrome, I guess, that's related to clicking buttons on the computer to make things happen. And the providers have actually been treated for that. So this is kind of the new 4-part aim of providing healthcare. Next, Chloe. So this chart is just simply to give you a general idea of what determines health and what I'll spend a lot of time on it. If you look at the biggest thing that determines health, 40% of it is the patient's choices. The environment they live in is one, genetics obviously plays a big role, the medical care they're getting and the social determinants certainly make a difference. But essentially, achieving outcomes is all pretty much reliant on patient choices. And what I mean by that is, do they come for their visits when they should? Do they follow their regimens? Do they follow their drug protocols? Do they go to referrals? What choices does a patient make to participate in their health? So you can see that and genetics, basically what is your family makeup? What is you have that want to see your family line? 70% of determines health are those two things. Medical care, 10%, the environment you live in, 5%, and the social determinants, other things, 15%. So I think that one of the things that health centers are focused on and continue to have to be focused on is how do we get the patients to be educated to make the right choices for their care. Next, Chloe. Thank you. So the social determinants of health, without reading off the slide, you can see them, the core determinants, race, ethnicity, veteran status, income, insurance, neighborhood. These are all pretty standard things that all of you have seen, I'm sure. The non-US domains, education, employment, material security, social integration, stress, and the optional things. These are all the things that drive that patient's ability to make their patient choices and their determinants of health. Next, Chloe, please. So value-based payment system today, essentially it's, payment performance for triple aim. It basically there's a base payment that says layer 1 base payment shifting from patient fee-for-service to per member per month. I think that most places are still living in a fee-for-service environment with some hybrid methods of capitation. Payment for delivery system transformation, PCMH, and other things. Partial capitation for care coordination. So you'll get a fee-for-service payment, and then if you have a patient-centered medical home and a patient-centered team, there are certain goals and objectives you may have added on that you can get a capitation payment on top of your fee-for-service for that. And then the performance on a triple aim, shared savings with upside only or upside and downside risk, typically through MCOs. And for those of us in the ACO world, this is getting to be a new thing. What's the risk corridor? What are the risk tracks? And how do we provide the care the patients need to be provided, but at the same time, minimize downside risk? And in the environment we're speaking about, downside risk would be the payer says to you, here's what you're going to get in terms of your PMPM for a patient. All the care has to be provided out of that. If you provide all of the care and you exceed that amount, you have a downside risk that you have to deal with. If you do it for less than that, you may be in a situation where you have shared savings. So it's kind of a different approach, and it's in Massachusetts in particular, in the ACO world, it's becoming a bigger piece of the pie than it used to be. Next, please, Chloe. So if you look at the NAC model, looking at other models, the value-based payment in primary care, the NAC in 2014, AAA performance, PCMH or PCHH, and prospective payment systems. Looking at it through another lens, you have the initial payments, care coordination fees, and then pay for performance, shared savings, and downside risk. So these are the kind of the two models. The NAC model, which a lot of us still work with, and we're kind of transitioning to this new model viewed through a different lens. Next, please, Chloe. So some of the measures used for payments, HEDIS, which I think a lot of us are familiar with, Healthcare Effectiveness Data Information Set. It provides measurement tools that are used to help us evaluate performance and clinical performance and quality customer service, as opposed to financial performance. So this is all about measurements that evaluate performance in terms of clinical quality. And HEDIS, as it says, is administered by the NCQA. Most of us are very, very familiar with them. So this is one measure. Next, please. Right, so Medicaid quality payment options, there's many, many, many of them. This is just to kind of give you a broad look at it, and we'll spend a lot of time on it. But I think depending upon what your contracts say and what your state and Mass Health or Medicaid people say, you can be participating in quality payments that are driven by HEDIS measures. They can be driven by measures that you agree with, that you negotiate and agree to in the contract with Medicaid or your MCOs. Every state is a little different, and every health center probably has something a little bit different, even within the same state. So it's just something to be aware of, that there are payments that are being tied now to quality that can improve the health center's reimbursement rates. Next, please. Yes, these are just some examples that when we were looking at this, I say we, Dave, did most of the legwork here, looking at what are the types of measures that could be used. And you can just read down the left-hand side, well care visits, ambulatory care, immunization status. And on the right side are just some of the suggested improvement targets that we were able to find in different situations. So if you were in a situation of looking at what kind of measures could be used for additional payments, these are some of the more common ones that we were able to find. Next, please. And this is specific to Maine. Dave had done some work looking at what was happening in the state of Maine. And if you look at this list, you see it's some of the stuff that we just saw in the previous screen is on there: well child visits, cervical cancer screening, breast cancer screening, prenatal care, the diabetes, retinal exam, HbA1c test, and lipid test. These are all pretty, I think, standard things, and lead screening in the first year and second year. These are actual measures that were used in the Maine's primary care profile. Next, please. So in this slide, we're just trying to make a point here that says patient-reported outcomes is kind of something that is a new thing that's coming. I don't know to what extent, but a lot of us already do this. We called it, in my health center was called the Patient Satisfaction Survey. And what we did was we wanted to find out from the patient, essentially your point of view on your health status. How do you feel about things? You know, how do you think you feel? How do you think you were treated today? The patient-reported outcome measures validate questionnaires. How do they think their health is versus what the providers are telling them? And then what kind of provider system survey questions we want to put on this form. In our health center, we would ask the patient, were you seen on time? How long did you wait in the room? How was it with the provider? Did you get enough attention? Did you understand what the provider was telling you? Did you leave with a good understanding of what you got out of that visit? How did the support staff help? Did you get out? How was your visit overall? And then we actually added things like, did you find the parking spot on time? Because we had a real problem with that. So this is kind of I think a more advanced version of what a lot of us might have already used as satisfaction surveys. Next, please. So like we've talked about, there are examples of measures to be used. There's a lot of them. There may be too many of them. They don't measure the same things. They don't work the same way. I think that you have to be able to understand what it is within your particular state, your particular environment, and what those measures should be. And also, what are your patient conditions? A lot of the measures that are used for payment should be tied to the type of patient services, the type of patient care you're providing. If you're in an area that has a lot of diabetic patients or a lot of asthmatic patients, a lot of your measures are probably going to be tied to those. But there's just a wide array of them, and we just want you to be aware that there's many of them. They change frequently. They vary state to state. And we get into session 4, we're going to make some assumptions and put together some examples, assuming some of these different payment methods. Next, please. Okay, so approaches to understanding cost. I mean, there's a lot of. Hello?
Hey, Bob?
Yeah.
Hey, sorry. A little late is better than never, right?
Okay, well, good. Then you can jump right in here.
Yeah, exactly. I apologize for the delay here. I think there was a problem with the time zones. Not everybody on the call here appreciates the fact that I'm calling in from quite a distance away in a completely different country in a different time zone. So there was a switch that happened between the time that I set this up and today, and I didn't realize that. So anyway, here we go. Thanks for picking up the slack while I was trying to get on here.
Okay, no problem. So you can see where we are, right?
Yeah, we're at the approaches to understanding costs associated
Yes.
with the new payment models. Yeah. Okay. Well, you'll get a different voice now, folks. I appreciate the patience, and Bob's picking up, being nimble and picking up the call. I was supposed to carry the lion's share of this call during this time, so we'll go from here. And Chloe's moving the slides along as we go, so this is great. So what we have here is the start of how we're going to deal with the issues that Bob's walked you through already. And I think where this slide started off, the conclusion was that we have a ton of options. There's almost more confusion in the marketplace than there is certainty when it comes to these value-based payment systems. So there's a methodology. Each of us in our different states are given a set of instructions, if you will, or some incentives, and we need to kind of walk through how we're going to use those. And we can't cover all 50 of them, so we're covering a few examples, and we're going to use one here later on in this presentation. So we start with that, as Bob was going to walk into here, we start with the average cost per patient as a base, and that comes from that presentation that we did, first presentation that we had. And then we talk about stratifying patients by intensity of needs, and that's going to be the use of care pathways and the like, which I'm going to see if we're where exactly we are on the presentation with that, but let me. We'll be talking about that in more detail and walking through how we would set this up, and then we'll be, that's how you're going to get your set your costs for determining those more intensive services due to you utilizing these care pathways. Okay, Chloe, you want to move it on? All right. So one of the first things we're going to do, and Bob, as we had talked about, you can chime in any of these places. You probably talked enough already. Yep. So at any of these points, you could step in. But what we're going to be talking about is how you go about grouping. As a first step is grouping your patients to simplify the costing. So there's a variety of different groups that you could use, and your particular health center may have a concentration of patients that falls into any of these or other groups. Healthy children, well visits, healthy adults, frail elderly. We're going to be concentrating on the fourth one, patients with a single chronic disease, in this case diabetes, but there's plenty of different groups that you could potentially have. And the important part in the chronic disease portion, especially if is to monitor these folks, is first to determine that they exist and get them into the groups if need be, and hopefully early, because relatively healthy patients, you want to have the emphasis on them taking responsibility for their health. So you may not be seeing them very often, but it's important that they step up and take some responsibility for their own health, even if it's to make sure they come in so that they can be diagnosed if, in fact, you need to be working with them in one of these groups on a preliminary basis, because they're showing early signs of potentially type 2 diabetes, and the earlier you can start interacting with them, the sooner you're going to be able to provide them some benefits. Okay, next slide. So this kind of goes about, the next two slides talk a little bit more about what we just said, which is that, that for a chronically ill, the emphasis on early detection and intervention. So you're trying to slow the disease progression, avoid the development of acute complications, and minimize the long-term costs of treatment. Now, there's a lot to think about there. I'm sure Bob discussed earlier on the call that we're in a situation where we need to also try to lower costs, and that sometimes leads us to consider our role within the whole management of people's health and the primary care basis as somewhat, we're definitely the tail that's being wagged by the dog, because we only account for a very small part of that, the cost equation. And to some extent, when we look at trying to reduce those costs, we think about maybe increasing the efficiency of our interactions and maybe reducing them, when in fact, more upfront costs might be required. We need to interact with our patients possibly more than we are now in order to reduce the cost down the road, even though those interactions may have an early upfront cost. Okay, next slide, Chloe. So these are just some of the interactions you might have to deal with on a diabetic patient, right? There's going to be interactions related directly to their diabetes. There are vascular issues, retinal issues, renal disease, hypertension, and all of these play a role in their outcome, right? And I'm sure Bob chatted about it, but the definition of outcomes and how we may define it as providers. I'll put myself in your guys' shoes. As providers, we may define ourselves a little differently than if we were the patient. The patient wants to get better, and if they're very complicated, that requires a lot of interventions to deal with a lot of different situations. And we need to measure that value of them getting better across the entire spectrum of their issues. So that means we need to intervene possibly on many different issues, and that's going to cost more, but also it's more complicated. So we need to be looking at all these different, especially for something as complicated as diabetes. And in future sessions, we'll be talking about behavioral health, HIV, using these examples, which are also extremely complicated. And we'll be talking through how that works to, on a cost basis, and how we go about getting those costs. Okay, Chloe, you can move on to the next slide. All right. So I apologize that these might be a little hard to read. Hopefully on your screen, this is still visible here, but I wanted to get all these reasons in on this slide here. So there are challenges to chronic disease management, and it's interesting, when this survey was done, and this is from the New England Journal of Medicine, when this survey was done for chronic diseases, you look at the top couple of reasons why chronic disease is difficult to deal with. And it's, you can read through it. Clinicians lack the necessary time for patients with chronic conditions. Well, we'll talk about how an intervention might allow for more time, because you're going to have team medicine involved. The patient's actually going to see people with different expertise, they may spend slightly less time with their doctor, but more time with a case manager, more time with a perhaps a behavioral health specialist, perhaps another type of a podiatrist, for instance, and a clinical pharmacist possibly. So in the clinic, they may spend more time. And so this is one way for us to deal with that. Insufficient care coordination. Well, you'll see in our example that care coordination is a key part of our approach along this particular care pathway, the one that we're choosing here. Patients lack the resources they need for self-management. Well, that's what, to some extent, that's what care management is all about. So you're going to help them, encourage them, provide, remove roadblocks and help them to get around that self-management, give them the resources they need. No formal organization strategy for chronic disease management. This is what we're going to be talking about is part of your strategy. That the clinical pathway is part of your strategy. And then, of course, the lack of team-based supports. Well, you'll see here that this is effectively a team-based solution. And we can keep going down this list, but in effect, what we've, the manager, the challenges that the providers have identified as being the roadblocks to good chronic disease management can be dealt with quite readily with the creation of these care pathways and how you then deal with patients in somewhat of a group setting. Doesn't mean you're dealing with them as a group like you would in, let's say, behavioral group setting, but you're dealing with them consistently. So you've brought them into a series of treatments, and you're going to be looking at treating them largely the same way. Obviously, every person's treatment is slightly different, but you're going to be hopefully able to set up a series of treatments by which everyone with chronic type 2 diabetes has access. So, Bob, does that ring any bells with how you set up your treatments at the center?
Yeah, I think the key thing was, for those of you who were with us back in sessions 1 and 2, the ability to do a lot of this stuff, it relies in how you determine you're going to track it in your electronic health record and in your general ledger. To be able to truly measure the cost and be able to truly report it out, you have to be isolating and capturing it that way. I also think that developing the clinical pathways in our health center, we identified that there were 5 patient conditions that represented 80% of what we did in the health center. And it was diabetics, asthmatics, congestive heart failure, COPD, and I always forget the last one, but there were 5 of them. And we actually took and developed a clinical pathway for each one, saying, when you're sitting in the room with a diabetic patient, the electronic health record had a prompt screen that would pop up and say, make sure you do these 5 or 6 things today for this patient, because this is what you need to do to treat their condition. And some of those 5 or 6 things also had billing components to it, where when you clicked off that you did it, it would pass it on to the encounter so that the provider in the room didn't have to worry a whole lot about it. It reminded them to do it, and then it took care of it downstream when they did it. We found that to be very, very successful. The challenge in the beginning was getting the clinical leadership to embrace that and realize that was a helpful tool versus hindering what the provider does in the exam room. Because I'm sure you've all heard that every provider has their own rhythm and their own way of doing things, and we can't follow a template. And we said, well, don't follow the template. Do whatever you want to do with it, and just do those things. So that was kind of what we dealt with, and it took us maybe 15, 16 months. We finally worked the kinks out in it.
Well, and as we go forward, Chloe, you can move on to the next slide. There is, in fact, a series of recommendations out there. You don't have to follow each one. You don't have to set your particular care pathway. It's the ones that are recommended online and what we're going to be talking about here. And as Bob just talked about, I mean, it's a matter of adapting what works, what doesn't work, what pieces are missing, what do we need to, how do we go about identifying what needs to be done. I'm not going to go through all of this. This is from the International Consortium of Health Outcomes, but clearly type 2 diabetes is an issue worldwide, and lots of people are working on it. And this just gives an idea of how many different types of outcomes there are that matter to people with diabetes, and the range is quite dramatic, and not everyone will prioritize this particular wheel of outcomes the same way. But you need to be at least aware that all these different factors could come into play. And it's interesting to hear Bob say that it took a lot of months. I mean, this isn't something you plug and play. You have to kind of talk with your patients, as you mentioned before, through surveys and the like. Obviously, the doctors and the providers are going to be talking to these people. What are they needing? What are they meeting? And to some extent, the outcomes, that the measurable parts of this will tell you whether you're effective or not. Okay, Chloe, you want to move on? Okay, so that's care pathways, as we've been talking about, clinical pathways, is a set of management guidelines using a form of flow chart. So you can create your own flow chart. That's one of the key things here. There are lots of examples out there at various centers in the literature. Perhaps at the PCA in your state is already starting to work on this. You can talk to your colleagues at other agencies, what they're doing. You don't have to start out with a blank slate, but you can certainly go and see what's been done and then modify it for your population and your group. So in its most complex, care pathway is a fully integrated information system. And that means that you also have, you may have to make adaptations to your EHR system and the like, and make sure that all of the people who are involved, and you'll see who we've put in as our, in our group that we've created later on in our example, have the skill set required to really help the situation and help these patients. Okay, next slide, Chloe. Apologize for the size of this a little bit. It got shrunk down a little bit, but this is an example of kind of a type 2 care diabetes pathway. And you can walk through this easily enough, and you can see where you start by identifying the people, as we talked about earlier on. Manage those at risk. It includes patient education, lifestyle advice, lowering blood pressure, managing cardiovascular risk. I mean, you can go through, and then each of these has some certain implications. So that's, this is kind of the first step in moving along. Next slide. All right, so one of the ways to do this, building this up, is through what we call process mapping. And you'll see in the next couple of slides how you would get your group together to do this. So again, we want you to use what the knowledge that's been built up in the industry as a whole, but to personalize it using the expertise of the people that you have on your teams, right? Your experts in this case are not necessarily just the doctors. They're the people and the providers. They're the people who have been working with these patients all the time. And that could be your existing care managers, could be behavioral health specialists, could be the clinical pharmacists, it could be the MAs who know a little bit more about the individuals and will be playing a role in this whole process. Okay, next slide. All right, so it's good if it involves sticky notes, right? So this is one potential way to do this. Every one of us has probably been in one of these group meetings where they hand out the sticky pads and like, okay, write stuff down and stick it up on the board. It actually is, in this case, one of the ways to go about creating your process map. It involves, you get a room full of all the people who would potentially be on this team or interacting with this team, or in the past have interacted with this particular set of patients, in our case, type 2 diabetics, but it could be any of those other groups we talked about. And, you have them walk through what are the steps, what should we be doing? What are the important elements of the visit? What are the patient's concerns? How do we ameliorate them? How do we deal with all the various aspects that could come in, longer necessary appointments? What happens if, a person's blood tests come back negative after some progress? I mean, where are the rooms and the providers and the various elements of this team actually sitting? Who's in the room with the patient as they meet, and then how long should that take? And lots to talk through. Okay, next slide. All right, so Bob, maybe I'll have you walk through some of this if you want, and then we're getting close to kicking into our example here.
Okay, so the measurement cost of care, we've talked about this in a couple of sessions, but it's the actual expense of patient care. It's not what we bill, not what we charge. It's all of the costs associated with that patient care. So it's all the salaries, the benefits, supplies, utilities that are used, everything that's provided for that cost, for that patient's care. And a lot of this comes right off the NAC bullet I talked about in the sessions. You know, ideally you want to measure it by patient, but certainly you can start with patients. My experience is we identified the cohort of patients we're going to work with, and we measured everything around those 100 or 200, whatever the number was, patients that were in that group we were looking at. But measure on a per patient basis. You may still be getting fee for service, but you can still take all of your costs and do it on a per visit basis, and then take discrete patients that were in that period of time and still get a per patient base. You also want to make sure it takes the full cycle of the patient's care, meaning not just that they're in the clinic today, but did you bring in a community support service person? Did you bring a nutritionist in? Did you bring a behavioral health person in? Now, what did we do for that particular full cycle of care for that patient's condition to get the outcome? So it's not, there are no lines here by department service line items. It's kind of open up whoever is involved in the process, and it can be people from many different parts of the health center. And the cost depends on the actual use of resources, the time that's devoted, what's the capacity of each resource, and the support cost. Again, a lot of this, it flashes back to sessions 1 and 2, but the time is kind of difficult. And I know in a health center environment, we're going to scale you a little bit further on with something we're going to talk about, but trying to measure time, like because a nurse is in a room talking to a diabetic patient now, leaves the room and is called to go across the hall to see a patient being treated for asthma. Well, that nurse's time is going to be hard to split between those two, unless you have a electronic system that does that, and that's a whole bunch of other things. But so getting the time, the capacity cost of each resource, and the support costs are the important to capture all the costs. You have anything to add, Dave? Good.
Okay, let's move on to the next slide then, because we walked through these steps here, 7 steps that Bob just talked about a little more granularly. So the first one is select a medical condition, as we just discussed, and define that care delivery value chain. So again, each, if we're going to use diabetics in this case, we've identified, we've gone through our little sticky note process mapping process, and we have created what we want that largely to be the patient experience when they're participating in this particular clinical pathway. Okay, next slide. So this is a little bit tougher time. It's obtain the time estimates for each process. We'll talk about this a little bit more in the next presentation, the last presentation here. We'll get down in the weeds a little bit farther. There are lots of ways to do this. So you could, there are software out there, there's packages, Kronos being one of them, where you literally tag in and tag out to every room, you know where everyone is. That's probably at any given time, and you can allocate to the minute. Some hospital systems apparently have tried that. It's quite complicated, as you imagine. We're not advocating you go that direction, but there are ways to set up those total costs based on timing that you can get off your UDS. You can use your productivity and break that down to average number of minutes. And through interacting with your providers, you can figure that out a little bit better for this particular kind of intervention we're talking about. Okay, next slide. This is, Bob can talk about this a little bit, but it's a flashback to our first session, which is, that step 5 is to estimate the cost of supplying the patient care resources. So that's, the provider cost, direct support, direct enabling, ancillary, and then over that we'll overlay the overhead costs later. But for this cost per visit from a operational point of view, this is your group of your costs you need to work with. Next. Step 6 is estimating the capacity. So this is something else we're going to talk a little bit more about in the final session. We're going to go through an example here momentarily. Well, you'll see how we came about creating this. But the capacity cost rate is an important element of how you kind of create some cost centers at which you can then multiply by number of people you're dealing with and come up to a total cost. But this is creating that capacity cost rate is a key portion of this. And it's throughout, resource pools and developing resources together, kind of pooling your resources as you hear, and costing that pool. Next step. I think we're kind of running slowly down. We want to leave some time for questions, so I'm moving along pretty quickly here. The last one is obviously just adding up all the total costs of patients. So this is where a lot of your, this is where you hit the home run in a sense. This is when, after you've done all the work before, you can roll up, the amount of costs you have, and then multiply the CCR of each resource by its, how long you used it for. This is on paper, right? No one visit is likely to fall exactly like this, but that's you're doing this over weeks and months and years, and you'll be able to cost these resources out. So before we move on to the example that we're going to talk about, Bob, do you have anything on these 7 steps? I kind of went through them kind of quickly.
No, I think that I keep harking back to the key to all of this is having your system set up to capture this slightly number 7, step 7, the cost of each process. I mean, I can't encourage you enough to, so once you identify that we're going to do this for diabetic patients, that you have a cost center in your general ledger that says, clinical care diabetics, and all of your salary costs go there, all of your support staff costs go there, all your supply costs go there, and any unique costs that go along with that are captured there. So when you are going to get the cost, you don't have to do much of anything other than run a statement. Here it is. And now I'll start breaking down your analysis with it.
All right. Next slide. All right. So here's our example of the world in which you're going to live in here in the future, right? So we're going to presume you're living in it now as we go through this example. So it's a mostly full risk-based, value-based reimbursement system, full risk. And you've got this group of diabetic patients, and you're paid we're going to actually show 3 scenarios, and also your existing steady state now, your fee-for-service environment. And assume you're moving along, you've been paying on fee-for-service, and now your ACO or the MCO or your state payers, Medicaid, are telling you you're going to go into this system, and we're going to just overlay it over the top of what you're doing now. And so we've come up with 3 scenarios plus the existing, like I mentioned, the existing fee-for-service one. And the 3 scenarios are you're paid a PMPM per rate, you get an add-on for care coordination, and then the third one is where you're at an actual, you're at risk, and there's upside and downside risk to this scenario. So they set a target threshold for a particular set of diagnostic results. And we're not going to go through that because that could vary by what type of group you put together, and even within a diabetic group, it might have different elements to it. But assume that it's at 50%. So if your results, if 50% of your group, less than 50% of your group, don't meet those specific parameters, then you owe back to the payment plan, the $250 a patient for every patient under that 50%. If you're at 50%, you owe nothing back, and there's no reward. You're just where you are. And over 50%, you earn $500 per patient for every patient over that 50% threshold. So hopefully you can all see where we're going here. 50s, you're at very base target. Under it, you get penalized, $250 patient for every patient under that 50% that meet your test conditions, and over, you get a reward. Okay, next slide. All right, hopefully, again, this is small, and a lot of these are a little bit, shrunken down, so hopefully you can see them on your screen okay. What we've done here is Bob put together some of these numbers from some existing groups that he'd worked with. Now, we're talking about a single group. You obviously could multiply this if you had more than one group. And we're talking about a variety of people who might participate in that group. So this first chart has to do with your staffing. And we have 2 physicians and a nurse practitioner that we're saying are available. And we give their costs, the time available to them. Effectively, we're only getting 52 weeks worth of this coverage. And we're just getting a full 1 FTE provider, 1 FTE clinical non-provider, the RNs, the LPNs, and then the other people that we're going to add in, the support folks. So that's how we're calculating these costs going forward. So that 179.4 you see is kind of an average cost for one of this mix of providers at the top line. And then we're going to bring in a clinical non-provider, an RN or an LPN, whose average cost is going to be somewhere around $74,000, $75,000. So you can see where that goes. Stays the same under each of these scenarios. It's down below that we make the difference, all right? So in the support is where we're showing how these scenarios vary. The first scenario just has a senior MA involved, right? You're paying them, this is their full-time job. You have enough patients that obviously this whole scenario business assumes you have enough patients to kind of fill your calendar with diabetic patients who are going through this clinical pathway. So you have an MA involved, and that's under your fee-for-service and scenario 1, where they've just introduced this new payment system to you. This is your that's your staffing plan. In scenario 2, you've added a case manager. And scenario 3, we've also added a nutritionist and a clinical pharmacist. Right? So here's where the costs start to dramatically differ. So you can see that the total line down below goes from $295 under the fee-for-service in scenario 1 to $347 to $576. And now we're talking, we've taken the leap here, if you will, and decided to add a substantial amount of cost to the center to provide care to these patients. And on its face, as we'll see as we move forward here, we'll talk through the revenue model first, but we'll see it as we go forward that, in fact, that's a big risk. I mean, there's potentially a lot of, there's substantial losses that potentially could be realized here. Bob, anything on this, or should we move to the next slide? You can talk through the revenue.
And I just want to remind everyone, we do have a couple minutes left of the presentation, but feel free to ask your question on the right-hand side of the GoTo chat box. We will be taking these questions after in a couple minutes.
Great. Thanks, Chloe. Next slide. All right, so we set up some productivity elements. We set up the visits, the number of visits, which were fairly consistent, number of patients were all consistent across all these scenarios. And then we assigned costs. So there was $130 is your PPS rate for the fee-for-service, $15 for your PMPM, $16 if you add this care coordinator in, and you stay at $16 under the total value-based plan because your upside is that. So next slide. All right, so this just walks through what I just mentioned. The visit stays the same for the most part, except in scenario 3, which is where we're seeing these people a lot more. That's part of the strategy here, right? We're going to encourage, because of the way we're being paid, we're going to encourage these people to see a lot more of you guys, come into the clinic much more often so that we can monitor their care. So we're literally looking at 6 visits a year as opposed to 2.88, which was the math prior. The 6 visits, we want to see them every other month. That was just kind of a general thing. So we walk down, you see what your patient revenue is, which came from the last slide. We added in an equal amount of grant contract revenue. You could also add pharmacy revenue possibly. Okay, next slide. All right, so this is kind of the crux of it and pretty much our last slide, then we'll go to the questions. So you add all those costs up, and you'll notice that we do have more supply costs for the bigger teams, and there's going to be a little higher subcontract costs, and there's going to be more overhead allocation. But let's go down to the subtotal. So here you are living in your fee-for-service world, and you're in a sense you're doing fine, right? You're at least breaking even under this scenario under fee-for-service. So financially, you think the system works, and this is where we've always been kind of attracted to. The patient outcomes, however, are only 25%. Before, that didn't really mean anything to you from a financial point of view. It wasn't good. You may or may not even have tracked it because you may not have had a benchmark that you were trying to measure against. But either way, you were doing okay under the fee-for-service world. Now, in scenario 1, you're getting the same situation, but you've got the same results, 25%, but now you're getting hit for a risk penalty for not meeting the threshold. That comes to $30,000 that you paid. That's $250 for every patient under 50%. Now all of a sudden, That doesn't work anymore, right? Scenario 1 says you're losing money under this new payment program and have to do something about that. So in scenario 2, you've added a care coordinator, but you've only gotten to 50%. So you've really only made it to the break-even level effectively, and not financially break even from the middle threshold level of results, but you haven't really you're not making money. And under scenario 3, you can see where even though our costs are dramatically higher, we got $500 for each of the 35% of our patients, because we came in at 85% of our patients were now meeting the outcome achievement award, that threshold. And we ended up with an upside, a shared savings, however you want to talk about it, of $4,000 to $14,000. So, Bob, you got comments on this as we wind up here?
Yeah, I think that my comment on this would be that each one of the scenarios presents a bottom line. Speaking as a CFO now, that I can tell you in our health center, we would have looked at this and said, okay, we can't do this because even 58,000 in scenario 3 to the good side is a very small return for the significant investment you're making. So we would try to go back and then say, well, are there ways to reduce some of the costs? Are there ways can we take this information and go to our payers or go to our ACO and say, look, we're providing all of this, but it's not financially viable. The $58,000 gives us no room for reinvestment in new procedures or new equipment or people or giving people raises. So although it's, even to slightly ahead of $58,000 basis, it still wouldn't be very attractive this way. I think you'd have to be approaching your ACO or your payers. You'd also have to be looking at, are there other ways to do it and reduce the cost?
So I think that's an important point. I mean, we set this example up to show how your intervention might cost you more money, but it could still end up being a better situation, both for your patients and for the health center. So there's nothing magical here. As you can imagine, we created the scenario to come out with this outcome. But Bob's point's really well taken. Your hurdle rate, if you will, what you need to be able to clear on these types of programs, to take the risk we're talking about, to hire as many people as you're talking about, is it could be a lot. You might need a much bigger bottom line before you'd take this leap. Okay.
And also, in some of these examples, I mean, it wouldn't take much to put these one way or the other. If you look at scenario 1 and 2, I mean, all it would take is missing by 5% or 10% to make those numbers significantly worse, or exceeding by 5 or 10% to make them significantly better. So I think that's kind of the balance here, is based on when you do this in your own environment, you have to look at history and say, what is the history of this program? Does it run on budget? Do I normally get the visits and patients that I plan for, or do I not? And then I think you have to do a second scenario saying, okay, what if we miss by 5%? What if we miss by 10%? Now, how do those numbers look?
Okay. Next slide. So session number 4 is going to be a little bit more of this with other examples. We're going to drill down a little bit farther into the how-tos of the costing mechanisms. And like I said, we'll come up with a few different scenarios to review. But we're going to be focusing on how you use this kind of information to make decisions at your center, programmatic decisions, because that's the world you're going to be facing here fairly soon, is that, you're going to be, especially, most of us have not had experience with downside risk, and that's coming. So, we need to be prepared for that. Okay, I think we're running over time here. We're going to go into the questions. Do we have questions?
Yes, I will be more than happy to answer any questions that did come in. And if you do have a question, feel free to reach out to any of these contacts on the screen. But again, we will be open for any questions through the go-to chat box located on the right-hand side. First question is, are there any FQHCs that are taking risk-based reimbursements?
I can speak for Greater Lawrence, and through their ACO, they are. The setup at Greater Lawrence is there's an ACO, which Greater Lawrence is part owner of, that's being billed on a fee-for-service basis for all the care the clinic provides. And then at the end of the fiscal year, there's a risk assessment that says if you exceed the total cost of care, then you have to make a payment to the ACO. And the risk corridors are, for the first 3 years, 75% is picked up by third-party administrators. Then the next year is 50%, and the next year after that is 25%, and in year 4, the health center is 100% responsible for risk. So that's the version of the risk that we had. But we didn't have any risk contracts with commercial payers or other payers other than through the ACO.
And there's also Oregon has the CCO program that coordinated care organizations, and they've got some up and downside risk associated with that. Though I think it's still evolving, but it's been in place probably longer, almost as long as Massachusetts, and so there's quite a bit of history there.
Thank you. And there's other two questions actually are asking about having the slides available for download, and I just want to set a reminder that the slides for today are in the handout section of the GoToWebinar toolbar, but you also will be able to download these slides and recordings through the Capital Link website, along with going through the Delta Center. So you can definitely reach out if you need to get these recordings, or you can just go online. And I also just wanted to circle back to Dave and Bob to see if there are any other last minute things that you would like to include in this presentation.
Well, no, I'll apologize again up front that I was late joining for interesting reasons, but I do want to hope everyone out there is staying safe, staying in their families, their colleagues and the staff and the health centers. I mean, it's probably hard to focus on costing when we're in this situation we're in right now, but our best wishes obviously extend to all of you. Bob,
I second that, and I also thank you for taking the time out to sit and join us, given everything that's going on. I greatly appreciate it.
Great.
Thank you. And we actually do have one question that came in that I will have you answer since we have just one more minute.
Sure.
Iowa is experiencing risk at different level within a VBC contract, and they would like to, that's something that actually looks like we can talk about through email. We can have Dave or Rob reach out to you actually.
Sure.
So yeah, it looks like yeah, perfect.
So
all right. Well, thank you, everyone.
Type those questions in. Yeah. We'll respond to every question we get directly to the questioner. So if you have a question that you think deals with just your particular situation, feel free to put it in there, and we'll get back to you.
Okay.
Thank you again, Bob and Dave. And after we close out the session, you will be directed to a very brief survey, and we appreciate any feedback that you're able to provide. And again, thank you for attending today's presentation, and look forward to joining us for the future presentations. Take care, everyone.
All right. Thank you. Bye.
Bye now.